Hello, everyone, and welcome to the Essential Substance Abuse Skills webinar series. I'm Kate Trams, and I will be administering today's webinar. Today, we have Dee LeBeau-Hein speaking on referral, service coordination, and documentation. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. We are one of 4 national focus centers serving the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. The series is designed to be a broad overview to assist in preparing for written alcohol and drug certification exams, to enhance existing knowledge, and to improve overall confidence in treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. Please check out our other upcoming webinars in this series, as well as our American Indian and Alaska Native Behavioral Health series, which takes place on the first Wednesday of each month. We always welcome suggestions of topics or speakers, so feel free to make suggestions either in the Q&A pod or by contacting me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and CEHs are available on request for a $15 fee. A request form is available for download in Files Pod in the webinar screen, and I will also be sending this form in a follow-up email to all who attended. Immediately following today's webinar, you'll be redirected to our GIPR evaluation. GIPR stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. The survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so if you have questions about the presentation or about the Adobe Connect system, please use the Q&A pod by typing them in the field at the bottom. We will address questions at appropriate points during the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Dee LeBeau-Hein. Dee is a member of the Minikuju Band of the Cheyenne River Sioux Tribe in Eagle Butte, South Dakota. She has recently worked as a mentor in the Tioshbai in engineering program at the South Dakota School of Mines and Technology and served as the president of the board of directors for the Sacred Heart Center, where she oversaw a women's shelter and an adolescent program. Dee, thank you so much for joining us, and I'll pass things over to you at this time.
Thank you, Kate. Good morning, everybody. I'm so glad you could join us for this webinar. I'm going to make the assumption that most of you are trainees. If not, this is a good overview for some of you that are already certified and in the field. We're looking at some of the 12 core functions. This is one of the core functions that you have to learn and understand, and how to document and refer. The referral process is actually the 12 core function that you need to be aware of. So this webinar really goes over how that process works, and when you refer somebody to for services outside of your agency, your organization, what coordination is involved, what kind of documentation you're going to have to keep up to speed in your files for your clients and such. So those are kind of the goals that we're going to be looking at. This is a recovery-oriented response. If you, for those of you that like to do research, I would encourage you to go seek out Dr. Kirk. How he developed this, he's got all the scientific data there for you, and he tells you about his case study and how he came to developing this particular approach to providing continuous treatment responses and promoting self-care. The way treatment programs are now approaching developing treatment plans, providing certain treatment curriculum and things like that, it all really gears from more engaging the client than it used to. They're adding a lot more services, a lot more coordination on the outside with other agencies. So there's really been a big shift in how counselors are approaching treatment care. And this recovery-oriented response kind of gets into some of that. So I would encourage you, if you really want to understand how this works, to go out there and look at how he designed this. It is very interesting. And what you're probably seeing, if you haven't already been exposed to this particular model, the ROSC model, this really sets the stage for all the entities out there that you're probably going to have, uh, you're going to be working with, or if not right now, in the future when you do your discharge summaries, and collaborating those kinds of client care for your client before and after they leave. So the recovery-oriented systems of care, the ROSC model, really is designed set for its client-centered, patient-centered. So all the systems that are involved it is an ongoing system. It's ongoing when you bring them in for orientation and do your intake process. These are some of the areas that you're probably going to identify that you're going to be continuing working with. So if they're coming in with if they're referred to your agency through Department of Social Services or from their work or from their housing authority, those are entities that you're going to be working with closely to share progress and completions and things like that with your referring agencies. So when you look at this diagram, you'll see this different types of services and supports that you have surrounding the client. Um, Really being mindful of the different areas that early on when they designed treatment programs, they used to just really go with the psychological uh, aspects of treatment and the physical aspects of treatment. Now they're realizing the psychosocial aspects of treatment and spirituality and how important that is in the recovery process for individuals in treatment. So they're incorporating that now into the diagrams and treatment process, and that's what you're seeing here with the wellness and health and recovery. So um, it's really important to engage these outside resources in your treatment planning, in your treatment process. When you're making your referrals, you're aware of these other areas of care. And if you see on the outside, with the goal of looking, things that you have to really be mindful of is, whether these other systems of care are if they're accessible, easily accessible for your client, how they're going to participate in these services, what your active role is going to be, what your client's active role is going to be. Do they have financial feasibility to pay for what they what you're referring them to, and what's the outside goal? I mean, this ROSC model is really important to familiarize yourself with, and it'll change as whatever you have in your community in terms of resources that you're going to be building to support your client's care. So looking at what a referral is basically you're sending a client to services that support their recovery process, and whatever those resources are in your community, those are the needs that you're going to be identifying in your clinical evaluation and or treatment planning. So like I said up front, when you're doing your initial intake, you're kind of identifying some of these sources kind of right up front, where who they're being referred to, what's the symptoms they're presenting with, what's their family dynamics, school dynamics, work dynamics, all those things. So you'll kind of get a feel for that right up front, what you're going to be looking for referral. Establishing and maintaining relationships. Now you have, like I said, in your different agencies, these different areas. I worked at a small tribal community where I'm from, and uh, there's there's some agencies that have, because we're a small agency, that have long-term employees, and others that had high turnover. So it was really important that I kept my referral contacts up to date as you're working with your clients and you're making those referrals. And sometimes they're very shy about going to new places and meeting new people if you refer them somewhere. But if you have a good dialogue with somebody that you're working in one of those referring agencies, you can kind of share that with them, and they know how to receive them. Whereas if you just tell them to go to a building and just check in at the front desk and you don't really lead them to somebody in particular, they might shy away and not go back. And this it may tell you that they didn't feel comfortable, or the person they wasn't there and they didn't really apply themselves. So it's for you as a clinician, it's really important for you to establish those working relationships with those folks and these entities and maintaining those relationships, because those are really going to help you um, with when you're making those referrals, but help you have that dialogue with that individual um, for the client's general well-being and outcome. So we've had clients that were looking for traditional healing. So we had spiritual leaders, spiritual elders, spiritual advisors in the community that we would refer our clients to um, for different things. They wanted to go participate in certain ceremonies or things like that. So those are some of the areas that you would I would really encourage you, if you don't already have a resource map or manual in your office, to develop one and have somebody tasked to maintain that, and then you guys can all work together with that. So you're always as when you're doing referrals, you're always working on assessing and evaluating your referral sources, like I mentioned. So you're wanting to nurture collaborative relationships, again, with those key contact people in those service organizations. In understanding, it's really important that you understand what their intake process is, what their evaluation process is, what model, if you're collaborating on dual diagnosis, and they're doing treatment with a psychiatrist or a psychologist or somebody, and what approach are they using, so you kind of understand what they're going to be working on over there, and you share with them what your agency's using. If your client-centered therapy or reality therapy or whatever you're using, you can have that dialogue and share that kind of information. So you're able to communicate not only clinically with your referring agency, but to process that down to your client so they understand what services they're going to be provided for when they get to that referring source. And giving that feedback to community resources regarding their service delivery. If somebody was rude or wasn't available or were constantly canceling appointments, or those are kinds of things that you want to communicate that with that individual or that service agency, and how important it is to be consistent and stable for the client's well-being and things like that. So those are really important to be mindful of. Differentiating between situations in which you refer your client or your client self-refers. Now, most residential treatment programs will refer clients to attend AA meetings or NA meetings, as part of their treatment plan. And the client may develop a rapport with somebody that does maybe women's groups, and they would rather just go to a women's group instead of going to an open AA meeting or a closed AA meeting. So those are some of the things that you want to talk to them about, the importance of why you're referring them to an AA group, or how would the women's group be beneficial to them, so you can make changes to their treatment plan if that's what you want to do. One of the things that I found, that some clients that were new to the process thought that AA groups were supposed to be some type of group therapy. So you really need to explain to your client that AA is a support group, and the differences between a support group and a therapeutic group setting, so they know that when they go to that AA meeting, they shouldn't be expecting to get some kind of intervention of therapeutic intervention. It's just a place to go and talk and get support and listen to other people's stories, and kind of relate that they're not alone in their addiction, or what they're dealing with. But I had a lot of clients come back that were confused with that process, saying I didn't get anything out of it, and it just seemed like everybody just sitting there complaining about their lives, and that's not what I was going there for. So I tried to explain, well, I did explain to them the differences in different types of AA meetings. You want to find a meeting that works well for you, that you relate to, but it's not there meant to for any therapeutic interventions. It's not set up for that. So it's important that you explain those different differences to them, and also so they understand when you develop those treatment plans with them, and how they how they're going to meet those goals, specific goals, or outcomes by their self referrals. So they understand, well, if this is you're going to do this, then you need to explain to me how this is going to help you in your recovery, short term or long term. So they're able to share that information with you. Assessing the patient's readiness and being where the patient is, you know, being able to identify and when a client's ready to go into group, or when a client's ready to go out into support groups, or when they're ready to take certain steps or measures on their own. It's important as a clinician to be able to identify that and assess that, so you know when it's time to make those referrals. um, so roll with resistance, and clients will tell you, most clients are pretty upfront and will tell you, no, I'm not ready for that. um, you got to be able to identify where a client might be in denial, or where they might have be coming from a fear base, or social, maybe they're antisocial for certain reasons or things like that. You need to be mindful of those things when you're making those referrals. So if they're rolling, if you're rolling with resistance, it's one thing. But if it looks like that you believe as a clinician they're capable and able, it's important to share that progress with them, while they're in your agency, in your program, and say, well, you've done really well here for the last, 4 weeks, and I think this would really be a big step for you to, engage in this process, and however you would share that with them, but to encourage that. And if they still resist, then you just say, okay, well, you let me know when you're ready. We have this available, and leave it at that. Leave it on the table for them, and they'll tell you. And then just kind of bring it up every now and again, and they'll let you know when they're ready. But at least you inform them and encourage them, and you shared the benefits to them, and they'll let you know when they're ready. So it's important that you engage that client in that process, and educating the client, and why you're referring them to those specific um, agencies. And you're going to want to arrange referrals to other professionals, agencies, community programs, or other appropriate resources. Like I said, you're gonna recognize that up front when you do your intake, and you're doing your treatment planning. You're going to identify those together, and you might even tell them up front. There, I may look at, down the road, when you get acclimated to the treatment program. You get involved in the treatment here. You At some point, I might want you to go out and get involved in a anger management group. Just for talk about some of these anger issues we've identified. Or a grief support group. So you're putting that bug in that client's ear, so they're mindful that that might be coming down the road. So it's not going to be new information when you share that with them. But these are just some of the you want to kind of uh, you don't want to cause any inadvertent cha- uh, change that's going to shake them up. Say, well, where did that come from? I had no idea you were even considering that. So it's important to identify those up front and keep that kind of dialogue going through your treatment process. And explain in clear and specific language the necessity for the process of referral. So that really ensures the patient, it helps them to ensure that they follow through, why they're going to go through it. And you're going to be a part of the process. You're going to stay in contact with that referring agency. You're going to be communicating with the client about um, the information that you're sharing with them. And so there's nothing secret squirrel stuff going on, that you're going to be talking directly with them, and the client will be involved in that process. So they're assured that they're being well cared for, and their primary um, quality of care is of your utmost concern. So exchanging relevant information with the agency or professional to whom the referral is being made. Um, you're going to want to be clear about that, because when you do releases of information, or you have them sign some kind of informed consent, that's going to be important of the specific information that you're going to be sharing with each other. Um, you're not going to get into their whole dynamics of their treatment process. If you're just referring them for grief um, counseling, then you keep it at that. If it's affecting their physical health because they're depressed, you're going to want to keep it at that. So you're not going to get involved in anything that doesn't pertain to what your referral um, dynamics are about. I mean, how it might ripple out and affect in the long term, that's one thing, but individually, you're going to want to maintain um, that specific uh, information when you share that with that agency. So when you evaluate the outcome of the referral, you're going to see specifically that they identified their grief, where their grief came from. You're going to identify how you worked on that, how the client worked on their grief, and what tools or plans they're going to have in the future if they experience another significant loss. So those are the kinds of things that you're going to want to be mindful of when you make those referrals. And when you're making those referrals, you're going to then begin to coordinate the types of services that you're going to be working um, with those referring agencies. So basically, service coordination is just that, the administrative, clinical, and evaluative activities that bring the patient, the treatment services, the community agency, and other resources together, and they focus on the issues and needs identified in the treatment plan. Now, this treatment plans can be modified, adjusted accordingly as you move through the treatment process. That's not uncommon to see, because you could be going through the treatment process. A client comes in presenting with a lot of depression, when in fact it's a lot of unresolved grief, um, or they come in with a lot of anxiety, and it's a process, and it's a product of something else. So you'd go in and might want to re-identify some of those treatment goals, or what you're going to be working on, outcomes and things. Um, so this is important to be mindful of. Don't be afraid to go back and adjust that accordingly as you need to. Um, so because it's important for the client to see that there's progress or regress in their treatment approach when they're with your agency. Um, Everybody likes to know that they're doing well, or if they're not doing well, why not? What can we do to help them do better? So just be mindful of that as you're collaborating with these coordinating those services. So as a coordinating service, you're going to be looking kind of basically case management. The residential facility that I worked with, we had an on-site case manager that I collaborated with when we were preparing to discharge a client back into their community. I would inform our case manager some of the services that we were looking for, like parenting classes, maybe uh, WIC, where they needed help with vouchers for milk or cereal, cheese, that you get in the WIC program, or Healthy Start, they needed help through that program. I would identify some of those areas, and then she would go out to those communities, and she would identify where those services were provided at, the location. She would get me a contact number, phone number, contact name, and things like that, and she would bring them back. And then we would sit down with her and the client, and when we were working on the discharge summary, we would inform them of what resources were available out in their community. And sometimes they didn't know that that was even available to them. What like they thought there was only one AA meeting, and there was four in their community. They didn't know that some of the church programs, what they were offering for certain types of services, and I mean just a variety of things to that care. And a patient advocacy, you as a counselor or a clinician may be that for that client, or you might have a actual patient advocate on staff. But this is kind of what they do. They'll go out there and they'll identify what resources there are, and with your guidance and the client's um, input, we'll start coordinating those services that best suit the client's recovery. So once you identify that, you've developed a framework of action for the client to start working on those goals that you've identified. On the bottom of the screen, you'll see a recovery month. That's really a neat resource. If you go into that site, you'll see a lot of good information there, and a lot of good links to go to get some ideas maybe of what you might want to work with your client on. Um, Along with the service coordination, so when you're collaborating with the client and possibly significant others, family, in Lakota we have a word called Tioshpaye, which is the extended family. um, you're going to want to be sure that they're included or they're aware if that's something, if they were involved in the treatment process with your client, that they're involved in the process. So if you're going to refer your client to parenting classes, for example, it's important that the significant other, if not agrees with it, is aware of it and why you're referring them for parenting classes and the benefits for that, outcome and things like that. So it's important that you collaborate with those individuals. And coordinating of treatment or referral services, the liaison activities with community resources. Now, again, you may be that as a clinician, or you might have somebody on staff that actually does this. But it's really, really important that you stay abreast of those resources and what they're providing, what services they are providing, and that you have a solid contact there. Because it is ongoing evaluation of the treatment progress. Um, we all know that treatment doesn't end when they graduate in 6 weeks or 4 weeks or however long your duration of your treatment um, program is. They go on to aftercare and then thereafter, you know, what they're going to be working on. So it is an ongoing process of evaluating what your client needs. Um, so service coordination includes implementing the treatment plan, like I mentioned earlier. You're collaborating with your referral sources. You're getting the information, reviewing it, and interpreting all the relevant screening, assessment, and initial treatment planning information. So when you're doing those screening processes or assessment and using your tools or whatever, you're getting this information in that process. You're confirming the patient's eligibility for admission and getting them ready for treatment and the changes that's involved. I've had clients come in that needed help with somebody to stay at their house while they were in treatment, or they needed help with other older children, or things like that. That you want to help them prepare for all that, what it's going to entail to come into the program, if it's a residential treatment program, or if you're set up as a intensive outpatient and they've got to be there for from 9 till 4. They've got to have daycare assistance or whatever services, or they might need transportation or things like that. You are approval to be away from work or whatever it is. You got to be ready to help that client participate in the program, and they're aware of what services you can do and what you can't do. Um, and complete necessary administrative procedures for admission to treatment. So you want to make sure you have all your release of information documents signed. You want to make sure you have the treatment plan is signed. You want to make sure your clinical supervisor, if you're a trainee, is signing off on your work, so everything's um, in order. If there was ever a call to look at things or question anything. So when you're implementing the treatment plan, you want to establish accurate treatment and recovery expectations with the patient and involve significant other. Again, I've had clients that come in that have a very protective significant other, and they try to sit in on um, sessions and manipulate the client or hinder the client from sharing specific information, especially in domestic violence situations. If there's domestic abuse going on in the home, those are things that you, as a clinician, I trust you're trained to recognize those things, and you know how to work with that situation. You may need to remove one one of the parties from the session for a while and then bring them in at a later time, or and confidentiality and privacy is huge in developing that rapport with your client. And it's important that they know that you are obligated um, by law to protect their confidentiality and privacy. so they understand that what that you they share with you stays with you, and you are not at liberty to discuss that with anybody without their consent, unless and only if they state that they want to hurt themselves or hurt somebody else, or if they identify and state that there's sexual abuse or sexual or child abuse going on in the home, you are obligated by law to report that. So it's important that you explain that to your client as you're implementing the treatment plan. You know that these are things that we want to help you with. We've got these tools that we're going to present to you, and these are what our expectations of you are going to be, and your responsibilities here, and these are our responsibilities here. Um, so it's important that is clear to the client, so they feel safe, they feel secure, and that they know that they can trust you, and that you're going to keep them involved in the treatment process for the duration of the treatment with you. So coordinating all these treatment activities with service providers, um, you want to, again, like I mentioned earlier, develop and maintain a community referral list, develop multidisciplinary collaborations within that community, accessible as needed. Um, we had, because we're in a rural community where I worked before, we had outside counselors coming in that were trained in trauma focused therapy that would come in and provide treatment to some of our clients that we referred to different treatment agencies, our counseling programs. So we knew that they would come in twice a week, Tuesdays and Thursdays, and we knew to collaborate with them, and that they would be at this location in the community, and we would make those referrals. And but sometimes if they wouldn't make, if we got a call that they weren't going to make it for whatever reason, weather related reasons or whatever, we knew to get a hold of the client and tell them it was canceled, or things like that. So it's important that you understand what is accessible and in the community, and keeping those schedules up to date and things like that. Deliver case presentations. So when you're coordinating these treatment activities with service providers, provide it to the patient by other resources. When you're delivering case presentations, be very clear and concise in sharing what it is that you're presenting. Um, if you want to be very specific, like I said, when you refer a client to a referring agency, because you want to make sure that that's the care that they're getting at that referring agency. You didn't ask them to refer them to another agency without the client's approval. You know, that wasn't discussed. So you have to be really clear in how you're coordinating and working those services out with your referring agency. Um, so you want to use appropriate technology to collect and interpret client treatment information for diverse sources. Today we have a lot of email scanning documents that are being sent, faxed, and things like that. So it's important that you are following HIPAA guidelines, and that you're not leaving anything out there for anybody outside of you or your clinical staff that can see that information, and how you're sharing that information with each other. That's really important. And how to interpret the client treatment information. So if I had a treatment counseling program that would come in to our community and provide the trauma care, I needed to understand what they were looking for in terms of um, treatment goals. You know, how did they know the client was progressing well in their individual treatment sessions? What indicators did they look for? And that helped me in documenting that information in my progress notes when I did sessions with my client, or updating their treatment plan or whatever I was working on. So that source documentation is important, and we'll get into some of that here shortly. So again, in the treatment plan, you're demonstrating an accurate, clear, and concise verbal and written communication. So if whatever reason you're not in the office and the client comes in and needs immediate session, any of your clinical staff should be able to pull your file, open it up, and get a clear idea of where you guys are at in the treatment process. So it's important when you're documenting your information in your client's file that you are clear and concise, and so anybody that reads it can get a clear picture of what you're working on. I had an individual client, colleague that would just all he would put in his his individual sessions was when I opened the file was we had an individual session 1 hour. That was it. I didn't know what they talked about. I didn't know what the client presented with. I didn't know, why they were there. I didn't know anything. So and sometimes it's hard for clients to rehash all that. They don't want to go through all that again. So be mindful as you're documenting what you're writing. So it's easy for someone else to pick up. Just kind of have that in the back of your mind. If someone else picks this file up, they need to understand what you're doing and why you're doing it. We had clinical staffings every morning that involved not only our clinical staff but our psychological team that we had on staff, and then our intake uh, gal that handled referrals that came in from the outside sources. And so we all sat down, and this was our interdisciplinary team, and we would sit and we would discuss the client's progress or regress, and if there was any referrals to be made, we discussed that, and then we would talk to the client. So you might participate in something like that already, or you may need to build something like that as you're working with those other agencies in your community. You may need to participate or develop an interdisciplinary team building um, for the benefit of that client. And maybe this might be new to some of those organizations, which it which could be a good thing because it begins that collaboration between your agency and another community resource. And it'll help in the long run, it'll help other clients. So you're also going to probably participate in negotiation, advocacy, conflict resolution, problem solving, and mediation. That seems to be ongoing with most clients. Assist in patient developing and maintaining contact. Face to face is a lot better for some, and some they don't do so well with that. I know we're getting into seeing virtual counseling where they're doing online counseling where they're just typing like messaging messenger counseling, and for some that may work and for some it doesn't. So it's important that you understand what those um, vehicles for delivering information is for your agency, but you're going to assist your client in developing and maintaining that contact, whether it be face to face, electronic, or telephone. What's best for you? You guys will determine that and establish that. And of course, document. And we're going to get into some of that here shortly. Summarize patient's personal and cultural background. It's important to understand that not one size fits all. Your client may not do well with groups, and if they don't do well with groups, what alternatives do you have? If they're going to do more individual sessions, do you as a clinician have time to do individual sessions? Do you need to refer them to another agency that will help you do individual sessions? Is that going to be more beneficial to the client than putting them into uncomfortably into group therapy settings at a point in their treatment that isn't going to be beneficial for them? So it's important that you understand that and that you identify those particular personal needs, and that you understand culturally what their background is. I had a client that was a fluent Lakota speaker, and she didn't do well sharing in group. She was okay being in group. She just didn't do well communicating in group because her frame of reference was first her native language, and then translating it into the English. So she didn't always feel comfortable sharing because she didn't think she was communicating it properly. So when I gave her assignments that were written assignments, she didn't understand some of the dialogue in those packets that I gave her. So I would sit down with her individually and just kind of read through them a little bit with her and kind of give her a gist of what we were looking for. So, like if it was a first step packet, I would explain to her why we were asking her, about the first step and what we were looking for, and in her words, share how she could answer some of those questions. So it's those kinds of things of understanding those cultural backgrounds, if they're Hispanic or um, Asian or whatever it might be. It's really important that you understand those points. So you want to be able to summarize this information um, in your coordinating with your agencies. You have your treatment plan, your recovery progress, and problems that might inhibit progress. So if they don't have reliable transportation, it's going to be hard for them to hit those meetings. It's going to be hard for them to hit those counseling sessions that you have. So it's important that you understand what you have to work with, and do the best you can to provide those services, resources to your client. And understand the terminology, the procedures and roles of other disciplines related to the treatment of substance use disorders. And that, again, as a clinician, you are responsible for understanding what your treatment modality that you're using in your treatment agency, or if you're going to refer them to another agency, you understand their modality that they're working with, so you understand what they're doing and why they're doing it and what approach they're taking. And you're able to explain that in a manner that the client can understand. So you as a clinician, that's your responsibility. Um, and to be able to see uh, how certain, because you're going to find that clients, because of the diversity in their person, but in their learning abilities, and sometimes even the drugs that they use, and sometimes there might be learning disabilities. You're going to have to be able to identify those um, sometimes barriers, but be able to get through those and um, refer them to the sources that'll be able to help them um, in their recovery process. So when you're consulting with somebody, you're contributing as a part of a multidisciplinary team. So whenever we sat, like I said, in our clinical staffing, um, we talked about, what was, how the client was doing, things that, issues that might have came up in group that wasn't discussed, and we feel like they need to, be referred over here for this, or, they need less of that, or, whatever it is, we discussed the general progress of the client. So you're contributing that information in those meetings. Um, so in essence, you're consulting with them, with each other, and sharing that information. And like I said, it's really important that you understand what your confidentiality regulations are in your agency, who you're referring them to, what resources out there in your community, what their confidentiality policies are, and such, so that you um, protect that client's confidentiality and privacy. So again, you want to maintain ongoing contact with your patient and involved significant others. Um, I want to make a note of the significant others. I had clients that, when they were in residential treatment with me, of course they have their drinking or using buddies that they, were their friends for life, but I said, well, while you're in treatment, we're going to begin to develop a sober support group, a support system for you. So who in your family, and I would have them identify who in their family were sober and they felt would support their recovery efforts. And they would make me a list. And then I would talk to them about those relationships they had with these individuals. And if they felt like if any of those individuals would be willing to come and begin the process of establishing that recovery support with them while they were in residential treatment. And a lot of them didn't think that their family members would. And in fact, they were more than willing to come and begin that process with them. So this is some of the stuff that it isn't written anywhere to do. But you, as a clinician, you want to be creative and you want to be mindful of some of those outside resources that might be available. It may not be their significant other, companion, because they might be why they're in there. So it might be Aunt Judy and Uncle Joe or Grandma Susie and, Grandpa John, whoever. You want to make sure that you start establishing that contact with them so they have that supportive resource and that structure prepared for them prior to leaving your treatment program. So when you're maintaining ongoing contact with those patients, you want to consider those other support entities out there. Um, and when the client is comfortable with that, they're not going to have a problem with you sharing information with them. They will be more than willing to sign a release of information that you can visit with them and check up with on them, or however you want to do it. But just keep that in mind as you're developing those contacts. And understand and recognize stages of change and other signs of treatment progress, because your client will go through those stages of changes. And there's a diagram here we're going to look at here in a sec. But you need to really be able to understand what those stages are. And there's resources out there that will identify certain points to say that this client is exhibiting this. Um, they appear to be in this stage. You'll be able to see that, and they'll hit those points. Um, and like I said, most clients like to see and know that they are making progress in treatment. An example of that, I had a client that relapsed. Um, some would say was a chronic relapser when before they come to our program. Um, and they would return, 2, 3 times. But one of the things I started noticing was they were discharged, and normally we would see them within, a couple weeks to a month. Well, this next time we discharged them, I didn't see them for 3 months. So they come in 3 months, and they were all, downtrodden, and they were feeling bad and ashamed. And, I relapsed again, and I said, you know what? You came back 3 months this time. The last time you were here was 3 weeks. So we've got progress here. You maintained your recovery a little bit longer. And their eyes, just got brighter, and they didn't realize that because they were caught up in, just feeling bad and hurt, self, you know, pity or whatever they were going through, and so when they seen that and they heard that, they were like, yeah, huh? And I said, so whatever you did different worked. So we start talking about that, and then they start recognizing some of the changes that really did make a difference for them. So it's those kinds of things that that you're going to want to communicate with your client. Make appropriate changes to the treatment plan to ensure that progress is being met. Again, if you're noticing that their support structure, people that are coming to visit them in treatment, are causing more um, dis- discord for them, or and disrupting their treatment, and they're not able to focus, then you probably need to look at that, because they're probably not adding to their supportive structure that you're trying to build for their recovery process. And it's being able to recognize those things. That's what's causing the client to regress, what's causing them to not participate in the program, what's going on there, and get in there and really identify that. And if you need to make adjustments again to your treatment plan, you're able to do so. Describe and document treatment process, progress, and outcome. That's kind of a given. You're going to be doing this ongoing through the duration of their treatment. Okay, so here's that diagram that I talked about. You'd see you have pre-contemplation. Okay, well, you have relapse, the client relapses, then you have pre-contemplation, and then contemplation, preparation, and action, and then maintenance. This is a treatment outcome measure that you can look at that is accepted, and you can Google this, or however, if you don't already have it in your agency, and be able to identify where a client is at. And it helps you continuing care, your relapse prevention. It's going to help you in your discharge planning. It's going to help you in your documentation, service coordination activities through your continuum of care, so you can identify where the client is at in their treatment process. Um, so this is really good to familiarize yourself with. Um, are they thinking about? Are they just knowing that they need to get into treatment, knowing that they need to be there in treatment? Are they kicking and screaming all the way through? Are you seeing that they're realizing it is important that they're at treatment? It's going to help them in the long run. Are they stepping up to the table and group, and they're starting to share more stuff? Are they asking more questions? Are they applying themselves to their treatment program? You know these, and then there you see those progressive changes. You're going to be able to recognize um, when they're ready to go to the next level of care. Okay, so now we have documentation. And again, when you're recording anything, these are all the things you have to record. You have to record your screening and intake process. A lot of you have screening tools that you use as a part of your intake process. So they come in and you might have a packet, that intake packet that the client has to fill out, or you go over it with them. I don't know how you do it, but some of those screening tools are designed to use not only in the onset of their treatment, but for the duration of their treatment. So I know SASE, as a screening tool, you use that in the beginning and then you use it towards the end of the treatment to see if there's any progress and changes in how they answer those questions. So be familiar with your screening tools, how they were developed, why they were developed, can they be used or should they be used later in the treatment process. Could help you with your discharge summary. That could help you with your referrals, um, in that kind of thing. So screening tools are really important to be familiar with. And that intake process is pretty a lot of your demographic, what they're presenting with, you're getting into your assessment. What's their drug of choice? What's their, are they polysubstance abuse users? Are they, is there psychological referrals needing to be done there? So your assessment's big. And then you get into your treatment plan, clinical reports that might come in from psychological evaluators, their clinical progress notes, your clinical progress notes, your discharge summaries, and those kinds of things. So anything that's related, patient-related data is going to be documented in the file. So like I said, if I come into your agency and I got referred one of your clients, I should be able to open that file and I should be able to see all this information in front of me, in some form or fashion. That's going to help me make a clear assessment of what kind of work has been done with that client. So demonstrate knowledge of accepted principles and patient record management. It needs to be done on a timely manner. You need to again be clear and concise of what you're documenting, and it needs to comply with regulations. So if you have somebody that comes in and audits your agency on an annual basis, talk to your clinical supervisor and familiarize yourself with their process, because they're going to tell you what exactly they're going to be looking for. They're going to tell you what principles or what is utilized in that process. Um, so you want to document information in an objective manner. Um, you need to, if you're not sure, ask again your clinical supervisor to maybe um, give you examples of what's appropriate, and what's not appropriate, and I trust they may have something like that available for you to look at. I'm very much research oriented, so when I get involved, when I go to new agencies, I look at different things to kind of get a gauge of where they're at and how they do things. And I'm not afraid to ask questions. So as a clinician, it's your responsibility to understand how to do this and have that knowledge of those accepted principles. The other thing is understanding how to protect your patient's rights to privacy and confidentiality, like I mentioned earlier. It's important that they understand that the only time that you would release any information, or you are obligated by law. It's like I said, if they're threatening to harm themselves or somebody else, or if there is sexual abuse or child abuse going on in the home, or that they want to report. If there's a gray area, talk to your clinical supervisor, and they'll help you with that, how to handle or approach that information. But you need to be aware of what your federal laws are. Like I said, we now have HIPAA compliance laws out there that have changed a bit. State and agency regulations. Working in a tribal agency, you might have a different privacy and confidentiality regulations there than you would in another agency. An example of that would be in working in a tribal program. We had the tribal council. A tribal council rep wanted information on a client in our program, and we were not um, in a position to, and nor should we be given any information to that tribal council representative. And they felt like because they were the governing body for the tribe, they had access. They were allowed access to that information, and we said no. So they were going to go to the tribal courts and to try to get that information. But even then, if they went to tribal court, any information that a court order comes down with has to be specific in what they're asking for. So you don't take the whole file out of the office and walk into the courtroom and say, okay, here's the file. What did you need to know? You don't do that. You need to be very specific about what is it that they're asking. It might be, um, how was the client attending successfully complete their uh, treatment program. That may be all they needed to know. And you have a completion date, you have, an answer was yes, that's all. So be very careful about what information you release to third parties, that you understand the regulations, that you understand those privacy and confidentiality um, rules. And understanding when you request or prepare and complete releases of information when appropriate, you are very clear and you're very specific about what you are releasing or what you are asking for from another agency. When I would do my assessments, one of the things I would talk to my clients about is if they had previous treatment experiences, I would ask them if it was okay if I could contact them to see what collaborate with the other treatment program to see what treatment modality they used, how the client did while they were there, what were some of the barriers, what were some of the successes, just kind of have that information. And I would explain to the client why I wanted that information. And 9 times out of 10, they didn't have a problem giving me that release of information, signing that for me, so I could communicate with other treatment programs. Because as much information as you can gather um, to help assess um, developing a treatment plan with your client, the better. So but be very clear about what you're asking for, and explaining why you're needing that information to your clients so they understand what you're doing, and that's all you're going to get from that person. You shouldn't and if you had to call for any other reason, you're going to get be more specific about what your information you're getting. So be mindful of that as you're familiarizing yourself with those privacy and confidentiality regulations. So preparing accurate and concise screening, intake, and assessment reports. Again, we have psychoactive substance use and abuse history. Sometimes clients come in presenting with alcohol use, and they might come back to the treatment center. Now they're presenting with cannabis or crack or something, and it's different. So you need to really be mindful of that history, what they're coming in, their progression of their use. Physical health, we had a lot of clients coming in that were diabetic and they weren't taking care of themselves or had heart disease. And while they were on their binge using or whatever, they weren't taking care of their physical health. So we had to, most of you probably do they have to have a physical before they come into your program. They have to be up to date on their shots and TB tests and things like that. So their physical health, you need to be really understanding of that and being able to report that if that's part of their treatment plan, that they're going to start working on their diabetes, managing their diabetes or whatever that might be. Any kind of psychological information, any kind of dialogue you have with if they've worked in the past with a um, uh, mental health institution or counselor, psychologist, then you're going to want to document that information. Any kind of social information, if they are involved in anything on the outside, their legal dynamics, gender identity, if there's issues there, cultural orientation, anything that presents while you're having that initial contact with your client. These are all areas that you're going to document. Again, you want to be very specific and you want to be very clear and very concise. If you're not sure, ask a clinical supervisor or a colleague to help you. Record treatment and continuing care plans that are consistent with agency standards and comply with applicable administrative rules. So again, you if you're new with your agency, or if you've ever had questions why you use certain forms or why things are set up the way they are, get behind it and figure it out so you can understand why you're asking for this information. So like I said, you want to comply with applicable administrative rules when you get in those informed consents. Um, you want to document in a timely manner. Most of you, if you have to report to a state agency, you have to document this information. They want weekly reports, or your progress notes have to be posted in a certain amount of hours. And if you're doing group therapy, you have to document your progress group notes at a certain time and get those report it. So um, you probably are already aware of your time constraints on that. There's always a paperwork, always paperwork. Recognize the importance of recording treatment and continuing care plans. Um, so if you're looking at like your aftercare treatment planning, your discharge summaries, you recognize how that applies with your um, treatment plan, and you're documenting all that information accordingly. Um, you want to record progress of the patient in relation to their treatment goals and objectives. You want to use appropriate clinical terminology. I don't know if most of your programs today are using the ASAM criteria. If you're not familiar with that, that's really a good uh, program to use. And because it gives you really good examples. If you don't have the manual on your resource table at work, you might want to talk to your clinical supervisor about that, because it helps you write um, some of these treatment goals and objectives in a manner that's appropriate for um, for the clinical terminology that you'll be using. Review and update your records ongoing. That should be ongoing, because when you're audited, they're going to look at dates when you have release of information signed. They got to be on an annual basis. You can't have 2-year-old release of information in the file. It has to be updated. Um, if you need to be sure you prepare it clear and legibly, of course. Document changes in the treatment plan as needed. Um, so just it's important that you record all this information in their progress in their treatment plan, and it meets those goals and objectives. You want to prepare concise and accurate discharge summaries. Like I said early on, when I had my case manager come in and we talked about what we were sending our client to do when they left the treatment program, we made sure that they had the resources available to do so. So if they had an appointment on Tuesday at 1 o'clock to go to a parenting class, my case manager was there picking them up. If they didn't have a ride, she would make sure she would be there to pick them up and take them to their appointments. So we collaborated on those kinds of things. So it's important that you when you're doing your discharge summaries, that you understand what is available for them and what is realistic for them to do. I would never ask my client to attend 3 AA meetings a week if they didn't like AA meetings, two, they didn't have a vehicle to get to AA meetings, and three, um, they just didn't want to do it. I wouldn't put that on a discharge summary, because I'm setting them up for failure. I would ask them, if you're not going to go to an AA meeting, what support group or what can you do that's going to support this goal that we're talking about in your recovery process? What resources are available and what are you willing to do? And then we would identify that resource. So it's important, as you're doing that you document those reasons. If it's outside of the norm of support groups, you want to be sure that you document why you're doing that and how it's going to meet the goal and achieve the outcome that you're looking for. So you want to prepare accurate and concise discharge summaries that have the patient profile and demographics. That's a given. Most of them are already set up that way. Presenting symptoms, your diagnosis, your selected interventions, because you might switch interventions as you're moving through the treatment progress. Critical incidents that might have happened prior to treatment, during treatment, or however that works, you identify those. Progress towards treatment goals, the outcome after care plan, and any other recommendations that you might have. I worked closely with parole officers. A client would come into our residential program on probation, or they were paroled into our facility. So I work closely with probation officers, our parole officers, and I would make recommendations accordingly if and when they got off of their probation. They worked with us based on those recommendations. So um, again, that's an agency again, that you may find yourself working with. Um, so documenting treatment outcomes using those accepted methods and instruments. So how you gather and record outcome data. Most of your agencies, your programs already have that established. How you incorporate that outcome measures during the treatment process, and recognizing that treatment and evaluation should occur simultaneously, so that treatment and evaluation they should be working together. Appreciate the importance of using data to improve clinical practices. So um, if you have that data might be collected from an outside source that's going to use that to help bring funding into your organization to help provide additional maybe resources in your education program or something. Those are some of those examples of why you would. It's important to gather that data because it can be used in a positive way down the road. So you have community case management with the strength perspective, believing with the premise that everybody has strengths, everybody has something behind them that's their strength, and everybody has weaknesses. In the strengths perspective, they're going to seek to encourage patients to become more deeply involved in their own treatment, which they take ownership for it, which is why today there's a big push of collaborating more with the client and getting them more involved instead of the clinician making all the decisions and saying, well, this is what you need and this is what I think and this is where we're going to do without the client's participation. They found that that doesn't work so well. Um, so simultaneously assist patients in learning how to acquire and retain resources that will support their recovery. I've ran into clients that have gone through my program and are still sober. They're still working a recovery program. And so when we have time to talk, they'll share with me what they've done different. They'll share how they were involved and what they started looking for, things that they were mindful of that they learned in treatment, that establishing relationships with people, what they're that didn't share certain same approaches to how they approach their recovery. That meant a lot to them, so they were careful on how they what relationships they found themselves in, and what even what kind of work hours that they were able to commit to that wouldn't take away from the family and cause less stress, and so just things like that. They were aware of those things by being a part of that and recognizing those triggers or those um, areas in their life that cause stress or that cause some of those relapse triggers. They were able to recognize those and be a part of that, so they were able to um, put that into practice in their recovery. So as a case manager, see, here's some of those principles that you might be familiar with or you want to be. If you as a clinician are acting as part of the case manager, I know a lot of our clinical programs aren't funded the way we'd like them to be, and they're not staffed the way that we would like them to be, so we often play that role. But these are areas that you want to make sure that you're facilitating the patient's identification of his or her strengths, abilities, and assets. They're all there. Assist the patient in focusing goals, identifying alternatives, and locating resources by encouraging the client to identify his or her own needs. Um, like I said, most clients are very aware of their shortcomings. You don't have to act. They'll give you a whole good old long list of what they don't do well, how they don't feel good about themselves, and all those things. You might need to help them identify what those positive attributes are for them. And once they start recognizing that and see that, and that's being reinforced through the progress through the duration of their treatment program, they're going to start identifying more. And it's also, if you do the positive affirmation building in group, that's another resource that you could use. They have to have one positive thing to a group member in what they've seen in as a strength or a positive, and that helps them to identify those positive attributes in others. And then when they hear it for themselves, that builds their self confidence and their identity. So those are just some areas that you want to be extra sidebar hint. Encourage positive, proactive identification of resources in the patient's environment. So again, like I said, friends, families, and neighbors, you want to identify those. I would encourage you to identify those up front, prior to or during the course of your treatment. But once they leave your program, you want to hope that they have that established for them, so they can just kind of transition smoothly into that support structure. Work with patients in the community to maximize the fidelity of the provider's perceptions and the patient's experience. You want to work closely with your client in the community, and who you're sending them to, um, and how they're perceiving that um, referring source and their experience. You want to stay close on that, so you know that they're getting the care they need, that there is progress happening, and if not, why, and you want to be able to address those issues. Um, Case management research, comparing research results across case management oriented programs is difficult because of the way the case management concept is defined. So more study is needed regarding the degrees to which the type of program influences retention, because you want to, they're always asking what your recidivism rate is, which means how many people are coming back, how many people are recurring back through your treatment program. You want to reduce your recidivism rate. You don't want to have them coming back anymore, or you hope to have that less. But so you want to find out what those are. So this is why it's important to document everything, why it's important to put that data and that information, because these are some of the things that they're looking at, trying to refine and find ways that's going to benefit not only the agency but the client care. Here's some research sites that you have access to. I've gone to most of them. They've got really good information on them. I would strongly encourage you to nose around when you get some time and just see what's out there, what's available for research for you as a clinician, for your agency, and for the clients. So to summarize, your referral is one of your 12 core functions that you have to know. If you're looking to go for a testing, for a certification, you're going to need to understand what the referral process is about. You're going to want to understand documentation, what service coordination is. You're going to want to understand, the community case management model is just an introduction of that strengths perspective, and then why it's important to do research, why it's important to do the data. So I hope I've given you a clear picture of these areas in your treatment programs and treatment progress, treatment planning. Um, I'm open for any questions that you might have. Um, I welcome any questions you might have, whether it be today or down the road. ATTC has access to my email and such, so they can send me whatever they need to. If you think of something down the road, and if there's something I can discuss with you or help you with, I'd be more than happy to. I appreciate the time that you take to understand and learn these things. As clinicians, you are on the front line of addressing and um, having an effect on making those positive changes for our clients that come in looking to get well, for their benefit, for their family's benefit, for the community. And I just want to thank you for your commitment in doing that in this field of work, because it's not easy. It's a lot of work. Sometimes it's a thankless job, but we don't always get pats on the back. But when we see another person in recovery down the road and we see them healthy and happy and they're working and they're excelling in their life, it's all worth it. It's all worth it. So with that, I'll end. I want to thank you.
Wonderful. Thanks so much, Dee. And yeah, like she said, I just also want to echo her thanks for everyone joining us today. Um, and please type in some questions if you have those. We got a few minutes. We can take some questions. If if you have your presentation in full screen mode, you'll need to exit out of that to access the Q&A pod, which is just to the right of the presentation. And you can type in the field at the bottom of that box. Okay. So we just have a couple of comments, I think. No questions at this point, so I will just go ahead and remind people that we will be sending out follow-up emails in the next 24 hours. They'll include a link to the recording of this webinar in case you missed it or in case you want to share it with other colleagues. It'll also include a link to the survey in case you are not redirected after we close, and the CEH request form. So if you would like to request CEHs for this event, you'll need that, as well as handouts for the presentation. And I'll just put up our upcoming webinars again so you can take a look at what we've got in the near future. And I think that's probably all we have then for today. So I just want to say thanks again to Dee for sharing her experience and her insight and just with helping get through all of this this content. There's a lot to cover. So thank you so much, Dee, and thanks everyone for joining us. And yeah, Dee, I'll let you say anything if you have anything else you wanted to conclude with.
No, like I said, I'm available for questions. Sometimes, it's a lot to digest. So as they're actually engaged in processing, something might come up that they remembered from this webinar that they had a question on. I'm more than open to answering any questions down the road if anybody has anything. So that's all I have.
Wonderful. Thank you so much. And again, thanks for joining us. And I hope we see you in a couple of weeks when we'll be doing our behavioral health webinar on clinical supervision. And then the next one in this series is I believe it's, let me see, it's the clinical evaluation screening on February 17th. So look forward to seeing you all then. Thanks so much.
Thanks, Kate.
Sorry, I'm about to close out, but I need to make sure I have the correct URL up for the survey. So here we go. Thanks again.